For tuning in. My name's Stephen Knowles and I'm talking to you from Brisbane. I established the Alpha-1 Association of Australia in 2005. This is the first of what hopefully will be a series of webinars aiming to keep Australians informed of all aspects of Alpha-1 Antitrypsin Deficiency. The webinars will be arranged by the Alpha-1 Association of Australia in collaboration with Alpha-1 Global. Our first webinar about Alpha-1 generally will be delivered by Dr. Jonathan Burdon of Melbourne. Dr. Burdon has been a respiratory physician for over 35 years, during which time he's always had a special interest in Alpha-1 out of St Vincent's Hospital in Melbourne. You may have questions along the way. Please feel free to post them. You can do this by clicking on a small bar containing a Q&A icon, which you should see in the top left corner of your screen. Dr. Burdon will endeavour to answer as many questions as possible at the end of his presentation. If there's insufficient time to answer all questions, we'll arrange for answers to be posted to the AAA discussion forums later. If you haven't already joined the discussion forums, you'll find a link to them from the front page of the AAA website. Over to Dr. Burdon.
Good morning, everybody, and thank you for the introduction. I've been involved with and interested in Alpha-1 Antitrypsin Deficiency since I was a junior. When I was a research fellow at the Royal Melbourne Hospital, my boss got involved with an Alpha-1 antitrypsin and hereditary investigation over at the Melbourne University. And my job was to collect blood from the patients with Alpha-1 Antitrypsin Deficiency and make sure they had their lung function test done, and I was sort of generally the gopher. After I finished my research at the Royal Melbourne Hospital, I travelled overseas to study for a couple of years. But when I came back to Australia, I was appointed as a respiratory physician at St Vincent's Hospital in Melbourne. And soon after I arrived, Professor Edward Yanis, who did a PhD in Alpha-1 Antitrypsin Deficiency in Christchurch, joined the staff at St Vincent's, and we started a major collaboration which continues there today. Sadly, he and I are no longer on the staff there, but the unit continues with Alpha-1 antitrypsin as a deficiency, as a particular interest. So I've had a very long experience with this condition, and in particular in relation to lung disease. Not surprisingly, given that I'm a respiratory physician, but we've also had interest in the other aspects clinically of Alpha-1 antitrypsin. Sue Brenton at St Vincent's Hospital, as the senior scientist in the respiratory laboratory there, has been involved with me for probably longer than she cares to remember with Alpha-1 antitrypsin, and does all the general running of the Alpha-1 antitrypsin program there, now under the direction of Dr. Matthew Conran, who's director of the department now. I thought today what we do is just talk generally about Alpha-1 antitrypsin deficiency, and in particular lung disease, because that's my specialty. But we will, as I said before, talk about other aspects of what happens. I think the first thing that we need to talk about is the hereditary aspects of Alpha-1 antitrypsin. It is a hereditary condition, and it's what we call an autosomal codominant condition. The best way to explain this, and I'm sure many of you will already understand this, but some of you may not. We know that lots of hereditary conditions are what we call dominant or recessive. If the condition is dominant, if you've got the gene, then you've got the condition. If it's recessive, then you have to have two genes. And as we all know, we get a gene for any of our characteristics, from one from each parent. Now, let's just take eye color, and in a general sense here, we'll just talk about brown eyes and blue eyes. Brown eyes, the gene for brown eyes is dominant. The gene for blue eyes is recessive. That means if you've got one parent giving you a brown-eyed gene and one parent giving you a blue-eyed gene, you will have brown eyes. To get blue eyes, you've got to have two blue-eyed genes. So that's the sort of situation with recessive and dominant. With alpha-1 antitrypsin deficiency, it's what we call codominant. That means each of the genes you get will exert an effect. So with alpha-1 antitrypsin, if you get one gene from one parent which is normal, that will give you, let's say, half the normal amount of alpha-1 antitrypsin in your blood. And the other gene from your other parent, if it's a normal one, you'll get the other half of the concentration, giving you a normal concentration. However, if one parent has a deficient gene, and one of the commonest deficient genes is the Z, and we call these PIZ, PI meaning proteinase inhibitor. If you get a Z from one parent, then you will get a very small amount of alpha-1 antitrypsin. So if you have a parent, one parent with giving you a gene, giving you a normal amount, that's the half normal, but the other parent gives you a smaller amount, they add together so that you might get, let's say, 3/4 of the normal concentration. So that's what we call autosomal codominant. The commonest genes, and we call them alleles. Alleles are just genes that are slightly changed from another. We've given it the name M. And why M? Because originally, when this condition was discovered, they worked out about this protein. The way they identified it was to put a spot of blood on one end of a gel, like gelatin you might have in your kitchen, and run an electric field across from one end to the other, and the proteins move up the gel, depending on their various electrical characteristics. And with the normal gene, it's sort of reached midway along the gel. So they thought, let's call it M because it's the middle of the alphabet, and we're sure to find some that go faster and some that go slower. And indeed, that's what happened, and that's how we find these days the phenotype. It is a bit difficult sometimes because with the null gene, and with the people with the null gene have, and if you've got two nulls, you have no alpha-1 antitrypsin at all. We don't see very many of those. Fortunately, it's very rare, but we do occasionally see someone who's got, let's say, M null or Z null, those sorts of things. So, and they have a intermediate amount of alpha-1 antitrypsin in their blood. But null genes are very difficult to detect on electrophoretic strips. So the genotyping is sometimes done, and that's actually more looking at the DNA, and it's a lot more complicated. The other commoner deficient gene is S, and that one in general terms gives you a small amount of alpha-1 antitrypsin, more than Z, but less than M. So we'd see people with combinations of MS, MM, MZ, ZZ, sometimes SS, and so forth. And we work out whether any of these people need treatment, which we'll talk about later, depending on the amount of alpha-1 antitrypsin they have in their blood, and whether that reaches what we call the protective threshold of 11 micromolar. The other thing about alpha-1 antitrypsin and the various different alleles is that it's important to know how much you have, what the concentration is. But the alleles also cause, it's not just about how much you've got, it's about how effective what you've got is. So you may have Z, which doesn't give you a lot, but Z doesn't work very well either. Whereas, for example, there's another one where PI Franklin, where people have a smaller amount than normal, but it works super well. So those people don't need treatment, and we don't see them presenting with lung disease. So that's sort of the situation. And when I first see patients with coming along to see me with alpha-1 antitrypsin related lung disease, one of the questions is, should we test the families? One of the interesting things we note is that the presenting person is usually the worst in the family. Why that is, we don't know, but my experience is, and my recommendation to the person presenting to me is, that you should tell the rest of the family that you've got this, and that they should seriously consider being tested, certainly all the adults. Whether children should be tested is a different matter, I think. My view is usually let's wait till they're teenagers and they can make their own mind up. So alpha-1 antitrypsin deficiency, we know, causes emphysema. That's one of the commonest things, and also causes liver disease. We see more liver disease in children, and it's usually that they're jaundiced for a while. That means they become a bit yellow. But in adults, we also see cirrhosis of the liver. That's a scarring process, and occasionally liver cancers. So that's the commonest things we see. At St Vincent's Hospital, we've got about 300 or 400 people with emphysema on our books. There's a couple of other rare conditions, a skin condition called necrotizing panniculitis, which can be associated with alpha-1 antitrypsin deficiency. And there is some talk, some thought that some patients with bronchiectasis, which is another lung disease, or a vasculitis, which is an inflammation of blood vessels, may be associated with alpha-1 antitrypsin deficiency. I don't think there's a lot of evidence about that right now, but that's certainly something that's coming up on the horizon. When I was talking about people who should be tested and why and the first patient who comes along is usually the worst in the family, it's an interesting observation, and it's not made just by me, but it's seen in the literature. One of the things we found when we were doing some of our research was that we know that alpha-1 antitrypsin is not the only protein which protects the lung and other organ systems against the development of emphysema or disease in other organ systems. And that alpha-1 is the main antiproteinase. And in this situation, let me explain, we have chemicals, compounds, molecules in our blood that are trying to destroy our tissues. We have chemicals, molecules in our blood that are protecting us. And alpha-1 is one of the protecting things. And it takes about 90%, we think, of provides about 90% of the protection. There are a few others, and the most common of the others is one called secretory leukocyte proteinase inhibitor, or SLPI, and there's another one called alafin, and there are a couple of others. And speculatively, I think that it's possible that those people with very severe alpha-1 antitrypsin deficiency have a deficiency in both alpha-1, should I say who have severe lung disease, have a deficiency of alpha-1 antitrypsin, but also a deficiency in some of the other antiproteinases, whereas the people we see who present with, let's say, mild lung disease, and I see people in their 60s and 70s who've only got very mild emphysema, and you'd wonder why. Clearly they've got alpha-1 antitrypsin deficiency. And it may be that they've got enough SLPI and the others, whereas the people with the severe disease don't. Now that's something that there's a little bit of evidence for, but it's still speculative. What about treatment? And I think that treatment for alpha-1 antitrypsin deficiency, the first thing is it's all about good lung health. That means people with this condition and people who are heterozygotes. That means that they have, let's say, a normal allele M and an abnormal allele, let's call it a Z for this exercise, so they're MZs. They should not smoke, and of course we would be telling everybody not to smoke. But certainly people with Alpha-1 antitrypsin deficiency or in their families should be encouraged not to smoke, as they will develop more severe lung disease. And even the people who are what I call the half and halves, M and Z, there's a small incidence of emphysema. It's usually not terribly severe, but 3 or 4% of those people will develop emphysema even if they're not smokers. So it's about good lung health. That means, as I say to my patients, it's what our mothers used to tell us: don't smoke, get adequate rest, have a sensible diet, and one shouldn't work in polluted environments, so don't work down the mines or in a dirty chemical factory or so forth. So those are the sort of common things. As people develop emphysema with alpha-1 antitrypsin deficiency, there are some medicines that we can use by inhalation, and they are the same ones we use for smoking-related emphysema. Alpha-1 antitrypsin replacement product has been available in Europe and America for many, many years, and it's been available by special permit in Australia for several decades, but very expensive in terms of the government wasn't funding it. So in Australia, it would be costing people about $100,000 a year. And with this type of treatment, there's no point in doing it for a year. You've got to do it forever. So in Australia, we've been a bit bereft. Fortunately, now the government has approved the use of alpha-1 antitrypsin replacement product in Australia, and we are now waiting for the government to arrange appropriate funding for it. So we're hoping that that may happen a bit later this year, but I've been in this game a very long time, and I've been waiting a long time, and but it will come sooner or later. So people with alpha-1 antitrypsin deficiency should be treated with a replacement product, and in most cases, I think it's a bit like having a blood transfusion. You just come in and have it once a week. My view is that once a fortnight is just as good. The only difference is we double the dose, and there's good evidence in the literature and in the practical field that I work in that this is entirely satisfactory and will protect the lung against the development of emphysema. Don't forget that after about the age of 25, we start losing lung function, whoever you are, and that's the process called aging. But we now have good evidence from the RAPID trial and others before that, that the rate of loss of lung function, the rate of development of emphysema, if you like, is significantly slowed by the replacement product. A couple of other things we should talk about in terms of treatment and those surgical approaches. Some people with severe alpha-1 antitrypsin related emphysema will undergo or may be considered for what we call lung volume reduction surgery. And in emphysema, one of the things is the lung is destroyed and forms cysts in the lung, and these can swell up and crush, if you like, squeeze a good lung. And lung volume reduction surgery is about just ablating those air-containing cysts and allowing the good lung to expand and be involved in gas exchange. And rarely, very occasionally, in very severe alpha-1 antitrypsin deficiency, lung transplantation is recommended. So those are the sort of standard treatments for at the present time. Gene therapy is just beginning to pop up on the horizon, and I think this is something where, let's watch this space and whether the one treatment and it'll be fixed, or what the regime will be is a bit difficult to be certain about at the time. But this is something that's popping up on the horizon. I suspect it'll be very costly, and again, we'll have a bit of a blue with the government about who's going to pay for it and so forth at the time. When we get Alpha-1 replacement product funded in Australia, I expect it will be funded only for certain specialised centres, and probably one or two of those centres will occur in each state. That doesn't mean to say, and I've been in discussion with the companies that produce Alpha-1 antitrypsin replacement product, and we all agree that whilst there'll be a specialist centre to which patients with this condition will be referred, it doesn't mean to say that your actual treatment can't be given more locally to your home at your general practitioners, and we're even talking about self-administration. So that's very much a watch this space. So I think in a nutshell, I've probably spoken too long now, but that's Alpha-1 antitrypsin deficiency and largely lung disease, because that's the commonest in a nutshell. And look, I'd be happy to take questions. Thank you.
Jonathan.
Yes?
John Arkenstall here. I'm a ZZ patient out in the Latrobe Valley in Victoria.
Yes, John, yep.
Have there been any trials or tests done on the cofactor proteases in terms of identifying people, identifying whether these are prevalent in people who are ZZ? I'm a comparatively asymptomatic ZZ. In my family, one sister's had a double lung transplant because of it.
Yep.
And the remaining three of us are all sitting there in the waiting room, so to speak.
With a sword hanging over your head, so to speak.
Yeah, well, yeah. It seems a fairly blunt sword on the basis of where we're all at. But
yes, yeah. Well, I'm pleased to hear that it's a blunt sword in your case, and I'm sorry about your sister. But no, there's not a lot of work been done on that, and it's something that I think.
Is it easy to test for?
Difficult.
Okay.
I was involved. I had a PhD student a few years ago, and we were looking at that. And there is some evidence for that, but again, it's early. There is some evidence, I think, from the Birmingham group in London, from Rob Stockley, along similar lines, but very early data.
Good, thank you.
One for you, Dr. Burdon, just in case it's of interest to others, but and I'm guessing that you probably know about as much as we all do, which is, how long do you think, do you feel, based on perhaps some other drugs, will funding be available, or a decision will be made by the National Blood Authority about the funding of Alpha-1 augmentation therapy?
I'm hoping it'll be this year. I know it's got to go through the various governmental processes, and it's got to go to COAG as well, I believe, to get sign-off. I've been quite active in pushing government, my professional societies and lung societies in Australia about acting as advocates. I'm of the view that getting the government to take notice is what I call a top-down and bottom-up. It means that people like me have got to start agitating, which I've been doing, and people with Alpha-1 antitrypsin deficiency have also got to wave the flag. Because remember, if people like me say this is a great thing, and the people with the disease don't say anything, then it's quite possible government will just say, well, you know, the doctors have got a new toy which they want to play with. But if we have people with the condition saying, you know, my condition's getting worse, I need the treatment, and why can't we have it? So hence a top down, bottom up, and I'm not saying which is top and which is bottom, but it's got to come from both sides, I think. I have met with the health department in Victoria, and I know that their representative said that they're very positive about it and very keen to get it going. So they're very supportive. But government moves in slow and mysterious ways. I'm hoping that by mid-year we'll have a decision from the National Blood Authority. But I remember back in 1984, I had a meeting with CSL at their request about looking at all this and investigating alpha-1 antitrypsin deficiency. I said, well, it would cost $1 million odd for what they wanted to do at the time. And basically, I've been waiting ever since. So, but I think we're getting down the sharp end. So those of you who are listening who've got alpha-1 antitrypsin deficiency, please do not despair. I think we are getting very close. So I'm hoping we'll have a decision by mid-year.
Dr. Burdon and Steve, this is Kevin. I do have a question from a CODIS here. CODIS, I'm going to unmute your microphone now, and you can go ahead and ask your question.
Hello.
Oh, hello, I'm Jean from Tasmania.
Hi, Jean.
And I've been agitating a little bit.
Good.
And writing to politicians. And I got a letter back from, I think, the Deputy Health Minister, Assistant Minister for Health, that said the last paragraph that, because my emphysema is fairly severe, I'm 62, that said that you should approach the public hospital via their local hospital therapeutics committee and see if they can fund the treatment, the antitrypsin treatment. So is it worth trying to do that, approach the hospitals, or not really?
Without giving names away, are you seeing a lung specialist about your condition?
Yeah.
Good. Then my approach here would be to discuss it with him or her and get him or her to take it up with the hospital.
Oh, well, I did try and discuss it with one lung specialist, and I'm thinking about trying to discuss it with one that's a bit closer. And he said, oh, they won't be able to afford it.
Well, that was what I was coming to next, is that I rather doubt that they will afford it because they're strapped for everything else. And at St Vincent's Hospital, I mean, I'm not on the staff there anymore, but I know they're not going to fund it. It's going to have to be funded from elsewhere. Although it may go through, in the fullness of time, when it is funded, the administration of it may go through a public hospital. And I would see that as entirely appropriate, but I can't see the pharmacy department at a public hospital or the administration approving something which may, let's say, cost them $1 million a year for 10 patients, 10 people. When they're already strapped, they'd be looking for. I mean, I hope for your sake and the sake of others that we get funding soon.
Yeah.
Okay.
Other questions, Kevin? Have you got anybody else?
That's
any other?
For now, I'm not seeing anybody else.
Kevin, can you hear me?
Yes, go ahead.
If you just check the chat panel, I just posted a question. Or I can Dr. Burdon, can you hear me?
Yes,
Oh, okay. I'll ask this question from Anne Thompson via Facebook. So she asks, her husband, ZZ Alpha, had a liver transplant last year. And she heard that once the old liver is gone and the new one is acting, then there's no longer a lack thereof of malfunctioning system via the actual deficiency thereof. I think she's suggesting there that there's no more malfunctioning Alpha-1. Her husband has growing severity with lung disease, cirrhosis, needing a lung transplant this year. We hope and pray, does this mean that the liver still processes this recessive gene? So I don't know if you caught all of that. I've pasted it. You should see it in your chat screen there also, but I have an answer there.
Yeah, I think if you've had a liver transplant, I'm sure that the people transplanting the liver will be certain that the donor liver is not one with alpha-1 antitrypsin issues, so that with a liver transplant, my view is I would expect that you would have a normal level of alpha-1 antitrypsin in the circulating blood, and that there should be no more problems with that liver. The lung disease associated in the same individual won't go away, of course, because emphysema is loss of lung tissue, does not grow back. And the lung disease should be treated on its merits, and it sounds like there's a lung transplant in train or about to happen, and I would expect once all that's happened, then there shouldn't be any further problems from the Alpha-1 point of view.
I can't see any further questions in any of the forums, so, but if we have missed any, we can post them later on, answers later on. I'll let you wind up, Dr. Burdon.
Well, thank you very much for everybody who's attended this webinar. I found it a interesting and useful thing to do, and as I say, I'm talking about one of my if doctors can have a favorite disease, this is one of mine, and it's always good to talk about it. I worry about the Alpha-1 group a lot, and I'm looking forward to seeing replacement product coming online in Australia at an affordable level that is funded by government in the not too distant future. So please keep in touch, send messages to Alpha-1 or communicate with my office or St Vincent's Hospital. Sue Brenton's the person to talk to, and we can take it from there. So thank you for joining us. Thank you to Stephen and Goni, and particularly Steve, who's been helping me with my computer and IT, because as I was saying to him early on, I'm not 15 anymore, so I find these things a little bit harder. So thank you for coming.